important way to move to the next phase of our conversation. If we can ask the panelists to come up, we've now had a little view of the possible. We've had a view of the challenges involved. We've had a view of the future, and we've had a bit of a view of the strategies. And now we're going to turn to a discussion of the action priorities for health system leaders. So if I can start my countdown again, but it's shorter, 5, 4, 3, 2, 1. It's now my pleasure to introduce and welcome, welcome Karen Guice. Karen is Executive Director in Ernst & Young's advisory practice. Before she joined Ernst & Young, she was the Acting Assistant Secretary of Defense for Health Affairs, ran the Health Affairs Enterprise at DoD. She has also recently been selected as one of the most influential women in health IT from the Healthcare Informatic and Management Systems Society, from HIMSS. And in addition, like Claire, is an alum of the National Academy of Medicine's Health Policy Program. So it's really a very special treat. Karen, thank you very much.
Appreciate it. Thank you very much. Well, good afternoon, everybody. And after that last panel, this one will be even more provocative, I think. So this panel is to actually talk about the strategic priorities for healthcare system leaders, as they each are one. And I'm going to not introduce them fully because their bios are obviously in the compendium for you all to read, but Admiral Bono is the Director of the Defense Health Agency. Jim Jirjis is with HCA Healthcare, and Kahn is with the Federation of American Hospitals. And each one of them is going to present just a few minutes of kind of where they sit and what they see about their strategic priorities for purchasing or procuring interoperability. So we'll start with Admiral Bono.
Thank you very much, Karen, and it's good to see you. I'm Rocky Bono. I'm the Director of the Defense Health Agency, and the reason that you want to pay attention to what I have to say is the Defense Health Agency is getting ready to oversee the entire military health system, which is a $50 billion a year industry. So now that I've got your attention, and so I appreciate what the other panelists said about what the incentives were, and I really appreciate when they finally came to the mic about what it really is. So what is it about the Defense Health Agency and the military health system that might be helpful for you to understand? Well, we have over 55 hospitals, and we have over 350 clinics that are dispersed across the United States as well as overseas. So we have a very broadly dispersed healthcare system. It is one of the largest federated ones, and we're looking for additional ways of partnering with our other federated partner, healthcare partner, and that's the VA. And you probably are familiar with some of their numbers. In that, when the Defense Health Agency starts overseeing the entire military health system, that means that the healthcare systems of Army medicine, Navy medicine, and Air Force medicine are going to come together and be overseen by the Defense Health Agency. And this is an important piece because in this healthcare space, what the military health system is attempting to do is create a value-based integrated system of readiness and health. And we're looking at that through a variety of lenses. If you haven't been able to ascertain by my brief description, what you see with the military health system is within our ecosphere of the military health system, we have oversight and control over the three main drivers for healthcare. The patients start out with us. We own the providers, per se. They belong to our system. We also own the healthcare plan. So with those as the levers and the drivers for healthcare, we're looking at ways that we can actually move towards that value creation in our healthcare system. interoperability happens to be one of the strategic characteristics of the way we're going to move towards that. And this is why we're paying really close attention to it. At the large level, I'm looking at nearly $1 billion in annual medical device replacement. There's a lot of interoperability represented by that. Across DoD, in IV pumps alone, I have about $100 million in IV pumps. I've got about 30,000 different types of IV pumps. We're just talking about IV pumps. In the Pacific Northwest, where we're just now launching our electronic health record, the Cerner Millennium product, I have found out that I've got 4,000 different types of IV pumps there. Only 3 of them meet the interoperability criteria that I need. Now, my interoperability criteria are slightly different than yours. I have to worry a lot more about cybersecurity, although I've heard some comments about cybersecurity. The environment from which I come from, cybersecurity is so high and so heightened that I have to take off my Fitbit before I can go into a meeting. Now, you may not know this, but your Fitbit is a beaconing device. So I suppose if somebody had a smart bomb and for some reason I became an attractive target, then they could beacon on my Fitbit. But that's how sensitized we are in the Department of Defense about cybersecurity. So as we've been launching our new electronic health record, thank you, Cerner, one of the things that has become very clear to me as we're moving towards this effort to create that value system of health is that as I look at what my strategic characteristic is in terms of interoperability, I have to look at how I can leverage the market force or how I can become a market force to help us move to that interoperability. Now, as I said, my interoperability requirements are slightly different. I'm going to be looking, of course, and this is something I'm sure is familiar to everybody here, I'm going to be looking at how well our devices interface with our new electronic health record. But I also have to look to see how well our medical devices are interoperable with all the other devices that I've bought. And I was just talking about IV pumps. As a trauma surgeon and critical care specialist, it became the norm for me to walk into an IC room and see 10 medical devices that didn't talk to each other. That's got to change, right? So I'm looking at interoperability through that lens as well. I've already told you about the security, cybersecurity. And I know there was a question about what do you do with legacy models. And so we do have a solution that we're having to use because I can't replace everything all at once. But we do have a solution set for what we're doing with those legacy medical devices that don't meet or can't be upgraded to meet the cyber requirements that we have in DoD. And then finally, what I have to look at is how well can I deploy some of these medical devices downrange? Because I need to be able to take care of the sailor, soldier, airman, or Marine that gets injured on the battlefield. And when I put a medical device like an IV pump downrange, I can't take the time to make sure that I'm training, that that person who's running that IV pump has had the requisite training to know what to do at that moment of injury. So I'm looking at interoperability from a very strategic and a very broad aperture. I also tend to see it as one of my strategic attributes in how we're moving forward as we move towards this enterprise approach to healthcare. And I think you've probably become aware of some of the conversations that are happening between DoD and VA, but we're looking for those opportunities that we can do even further collaboration because we realize that collectively as the 2 federated healthcare systems in the United States, and when we come together, then we're aggregating quite a lot besides our collective clinical expertise. And so when we're looking at interoperability, I hope that what we can do is help shape and inform how we're going to be procuring these devices going forward and being able to set those types of requirements in our procurement strategies moving forward to medical devices or any other electronic tool that we use in our medical system. So I look forward to the rest of the conversation, and I encourage you to ask me some very provocative and tough questions, because I think that's where the value of this meeting is. Thank you.
Yeah, I'm Jim Jirjis. I'm the Chief Health Information Officer for HCA Healthcare. And many of you probably know we're a $43 billion healthcare company with over 175 hospitals, 110 surgery centers, hundreds of urgent care, hundreds of primary care, freestanding ERs. And I say all that because part of our model has been to work with affiliate physicians, but we don't typically employ those physicians. So they use our hospital, and our goal is to make it easy for them and the patient to get care in our facilities. Well, we're at a crossroads in our company in healthcare where our leadership, they like to say, awakening to the power of our clinical data. And very quickly, about 7 milliseconds after they awaken to the power of our clinical data, is awakening to the problem of our interoperability, right? And I say that because times have changed. HCA strategically views healthcare as a highly information-intensive industry. The information has to flow. But moreover, some of the capabilities we hear about the big data, real-time machine learning, the idea that you could take apps and put them in the workflow. And we're buying 100,000 iPhones to put in our nurses' hands. Now there's a real opportunity to use that for real-time, just-in-time patient care. And so I say all that because times have changed, and our company, our CEO and COO of our company had a meeting with me one day because we had this giant data warehouse, and I'll avoid sharing the colorful metaphors for how large it is, but it involves solar systems and if you stacked up Post-it notes, how many trips to the sun? 30. But anyway, a lot of data, a lot of magical thinking used to happen. Our COO came to me one day and said, I want Edmund, your chief data scientist, to do 20 data science real-time projects next year. And I said, Sam, I sit in fear that you're gonna ask me for one more. He said, well, why? I said, and I walked with him through the journey of our 170 hospitals. Forget whether you have different EMRs. You can have the same one in different hospitals, and all the mnemonics are wrong, or are different. We had 708 different ways to say lactic acid for 11 LOINC codes. So I said, when you ask Edmund Jackson to do one more, he has to disappear for 3 months and do all the data semantic mapping and cleanup so he can do the 11.5 minutes of fancy magic. There is magic, by the way. No. Of the data science you want. He said, oh. So when I say we're awakening the power of our data, the world's changed, the technologies are there. The data science, deep learning, all that stuff's ready to be used. There's mobility, there's an ability to do service-oriented architecture, to not just have it be the desktop. All this is happening, and as the company wants to execute on it, what we're finding is the enormous lift in cost to not having semantic interoperability is tremendous. If we want to do real time, we've got to have, we can't have it be a giant science project with enormous millions of dollars and months to years before we can actually do an intervention, because we have to clean up and get data out of all these various devices across our 44 markets. We have the same problem you do. How do we do real time when we're going to use a pulse ox or we're going to use a ventilator? Most of the battle's not coming up with ideas. It's not even figuring out the people, processes, workflows, or what you want to measure. It's just getting the data operable. And I don't have to tell you the importance of the HIE, the information following the patient wherever they go, but my lands, I hope we land with something that goes beyond the CCD, because that's human interoperability. But if you ever sit down with a doctor who tries to read one of those continuity care documents, some of them can be 72 pages. So they're not really human consumable, and they're certainly not semantically interoperable for machine consumption. But the other big thing that has really changed for us is, we talked about quality and value. There are enough business cases right now that emphasize how in the way interoperability is that we don't have to dream up others. But I will tell you, as we talked about, as our affiliate providers are now engaged in MACRA, MIPS, the world has changed. It's not just about quality. Our customers are the patient, but they're also the provider and our 70,000 nurses, and there's a nursing shortage. We want to keep our patient outcomes good, our patient experience good, our physician and our nurse experience exceptional. So it's about efficiency of care. Help me do my job easier. And we have to help all of our affiliate providers be successful with their value-based care as it accelerates. So I say all that to say that we have awakened to the power of our data, but our C-suite has also awakened to the problem of interoperability. So our CEO is very engaged with this. I think he's on the board of the Center for Medical Interoperability. And because we believe that if we can move the puck on this, we're going to have no shortage of ideas for how we improve value. It's not just quality. I think someone said, if you don't get money for quality, well, it's about value. What are the patients, the employers who pay for care, and those who have to deliver the care? How are they able to do it? So what I would submit to you is we're very engaged. And in that document, bullet number 4, where it becomes clearer what that standard we want to point to is, we're very good at RFPs, steering committees, choke points where people don't sign contracts until we have selection processes that emphasize the procurement of devices that make it really easy for us to deliver better care. So we're very eager to actually have that forward motion so we can begin leveraging internally, but also, there's a lot of I don't think we're unique in all of these challenges. And so I think there will be tremendous alignment with all those other organizations and systems that are entrusted with the delivery of highly regulated care for our citizens. And so our belief is that, yes, there's a big ocean to boil, but we don't have to boil oceans. There will be a lot, we're hopeful that the standards for semantic interoperability will make Dr. Rucker's dream of the open API that is not constrained actually lead to markets for innovation. Because I'll tell you what, success number 1 is let's just look at HIE and device data. Success number 1 is all that data coming in. And then I would invite each of you to sit down next to a doctor that has to make sense of it, of that ocean of data. We need competition around apps, et cetera, that actually are better and better at actually presenting the data as a story, as someone said, as a narrative. So we're very excited about engaging increasingly because it's not just an email from me or, hey, we need interoperability, but our leaders feel the opportunity and they're frustrated with the lack of semantic interoperability. So we believe we can help with procurement, but it won't be enough. If in fact you have a sector where there's 3 products and none of them meet the interoperability standard, we'll probably need more than procurement because there's nothing to push to, and we'll probably in parallel need some help from others. But we believe we can and will be a strong supporter of moving forward with the incentives for the vendors to adhere.
I guess I'm the policy guy on the whole program here, and I'll sort of start from that perspective and then talk about value proposition. So from a policy standpoint, at least from my view and experience, I think rules drive it all, and for most providers and those who run hospitals, at a minimum, they've got to worry about the rules. I spent a number of years on Secretary Leavitt's AHIC, if you remember that from many years ago, and I can say that jawboning doesn't work. It's insufficient. So what did we learn from HighTech? Money and regulation push action. Whether it was always the right action or not, I think we could conclude it wasn't necessarily, but we saw the result. And whether or not procurement is a route to get there, and the model that's in the report, I think the key is going to be whether there's alignment between whatever the government decides the rules are going to be and the sort of 5-step process of institutions coming into line and developing their role for interoperability. I mean, frankly, from my conversations with my CEOs and other CEOs, what keeps you up at night? I mean, of course, you're worried about how well your institution's doing in terms of patient care and financing, but at the end of the day, you don't want the HHSIG, you don't want the Justice Department, and you don't want the trial bar knocking on your door. Because as soon as that happens, it doesn't matter what you're working on, you're done. Your time, your effort, and is going to be sapped up. So I'd say the first thing that we've got to make sure, because there is limited bandwidth in every institution, particularly managerially, to deal with the kind of commitments that are included in the report. I think it really is dependent on making sure that whatever the government comes out with in the rules, and we were talking about some of those earlier, that they facilitate and bring about alignment. They don't sort of pervert or send you in the wrong directions. And the issues of what happens with meaningful use down the line and other existing regulations have to be dealt with. I guess it's up to the authority and the current administration to figure that out. Second, in terms of the value proposition, I think from the standpoint of both patients, purchasers, and the government, there's sort of three important themes that to me have to be achieved through the endeavor that we're talking about, or it's not worth the time and effort. Three things. One, improvement, accountability, and transparency. So what do I mean? Well, first on the improvement side, and Jim just outlined it, if you can't from the process come up with the analytics that push the right kind of care for the patient at the bed as well as the whole populations, then the endeavor is not worth it. So we've got to make sure that it works for that. And second, from an institutional standpoint, accountability is frankly everything in terms of keeping your institution afloat. I mean, one, you've got to be accountable for the regulations, but two, payment is going to be tied to measurement as well as to ultimately your transparency. And if this enterprise doesn't provide the means for the kind of measurement that's going to be meaningful, rather than the measurement CMS requires now, then it's not worth the endeavor. So I'll just conclude by saying it's got to lead to improvement. It's got to enhance the ability of those providing care to be accountable. And then ultimately, transparency only works if it's based on useful data that really tells consumers what they're receiving. And I don't think our current measurement processes do that. I mean, have you been to Hospital Compare? It doesn't really tell you where to go if you're trying to decide what hospital to go to. So with that, I'll conclude.
Okay, so the first question I have is actually probably for Rocky and for John. It's how do you leverage all of your procurement opportunities across what you have under your control to push interoperability? And that, think about that broadly. We've talking a lot here about EMRs and devices, but are there other opportunities that you have at your disposal in the procurement process that can drive interoperability?
So for the Department of Defense, we have a very rigorous process in our procurement. And so in our statement of work, in our RFP, we have to put in there what our requirements are in terms of capabilities. In other words, if I want something like a writing device, I can't say that I want a Mont Blanc. I have to say that it is a writing implement that uses ink and can write upside down or something like that.
It's a pencil.
Or it's a pen. It could be, and they could show up with a pencil, right? So, but that's an important distinction because you have to be able to put in your RFP the requirement and the capabilities that you want from that requirement. And so if it were something where you wanted it to be erasable, then you could get one of those erasable ink pens as well. So that's a very rigorous process that we have in our procurement efforts in DoD, and it's very closely vetted with that, and that's how we go and compete that. Now, one of the advantages that we'll be able to have as the DHA, the Defense Health Agency, starts overseeing these efforts across the services is actually aggregating that and bringing those requirements together, and then being able to look across all of industry to see which are those vendors that best meet those procurement requirements. Does that get to what you were?
Well, the other thing I was thinking of, you have your TRICARE opportunities, and is that another way to drive interoperability by putting things? So one is you contract and develop it for your EMR and your devices, right. And you're very, very technical in that approach. But then the other approach where you just require people to make sure that they are actually able to send you the data. So you're working on both fronts, right? You're working on the push and the pull.
Right, and I think that's the other part. I'd mentioned that we also have oversee the actual healthcare plan. And so again, that is another contractual arrangement that we make with the commercial and the private sector. And so being able to put in our contracts for network development or our providers through that contract, we're able to put in there that degree of interoperability that we weren't able to drive before. And as a matter of fact, we're looking at ways of developing reimbursement models on being able to promote and extend our interoperability.
That too, yeah. So you mentioned other opportunities. Well, you know, we also have subsidiary companies like Health Trust, Parallon, where we actually provide EMR implementations, some purchasing. We already have a pretty large purchasing group, and so there would be very much aligned incentives to purchase around it. The other thing I would mention, and opportunities beyond just what we purchase. The other thing I'd like to mention is, you know, it's not lost on us that there's a parallel model that we would follow, that we've had to, that we've learned from, that I might encourage other systems to think about. Is a lot of the same things that are required to make sure the products that are being evaluated meet cybersecurity standards is a very similar type of process. We would want to promote and elevate this to the same type of importance for different reasons. For our reasons, it would be so we can deliver higher value healthcare, or we will be left behind. But we will exercise all of those same katas, if you will, skills, to move this up in the organization.
Okay, so I see cards already being held this way. Julian, you want to start off?
Yes, thank you. This is a question for Admiral Bono. Pardon me. In the past, it's been my experience that some organizations are okay with using procurement language to be aspirational. And actually, I apologize. I didn't mean to restrict it to you, but I know this has been an issue in the DoD specifically. So, you know, we're talking about procurement language, and if we were today to all release procurement language that required adherence to a spec that didn't exist, we would also be tacitly agreeing that it's somewhat aspirational. And so we might say that we would preferentially purchase equipment that had that, assuming it meets all other requirements. That approach seems to be acceptable to many organizations, at least, for example, to the organizations that I mentioned this morning that were signatories to MDFire, including the VA. But some organizations, and this has come up in the DoD, feel that's too restrictive, that someone might interpret the procurement language incorrectly and prevent purchasing much-needed clinical devices because they don't meet, you know, what should have been an aspirational specification, or one at least that should, you know, be more thoughtfully considered. So I'd like to present that because this has come up in the past. It seems like a core issue for us today. Is, you know, can we get into trouble in some organizations by having an aspirational specification?
That's a great question, and you can always get into trouble when you have aspirational language. But I think that here's the other piece that I think is an extremely important part of the conversation that we're having with industry, and that is we're actually having conversations with industry. Because that is something for DoD that is a new practice, and that is that we don't feel any longer, especially with Secretary Mattis and where he is hoping to bring the Department of Defense by introducing business reform into the DoD practices, is that we don't necessarily have to try and develop or invent some of our solutions. We recognize that out in industry, there is a tremendous amount of effort and innovation that's going on that we want to avail ourselves of that. So what we've started doing in the Defense Health Agency is we have these industry days and reverse industry days. And something like this where we design or we write an aspirational procurement document, what we do is we go ahead and put that out there for comment and get feedback from industry so that we can make sure that we are syncing with the right ways of describing where we're trying to go. That's an important piece of being able to have that conversation and increasing that crosstalk. Does that get to the question?
A little static. Yeah, thank you very much. In fact, you brought back a memory to me that when we first developed MDFire with Hopkins and Kaiser and partners, we circulated it to some very thoughtful industry experts who then advised us to modify some language so it wouldn't seem either objectionable or impossible. I had forgotten that cycle. I'm glad to hear that you have reverse industry day. That makes a lot of sense to share requirements.
Yes. Thank you.
Thank you.
Are there any other questions? Yes, sir.
On this conundrum, I'm curious, maybe more for you, Vice Admiral, on the issue of standards development. The public sector has played a pretty significant role in embracing standards development. Have you had any experience, in the document, any experience in a contractual vehicle obligating the partner that you're working with to join forces with you in accelerating standards development? In other words, I get the idea of buying a known standard, but in the capacity of collaborating in standards development or acceleration, has that been a strategy used in any other forum that you're aware of?
So it helps us in our procurement language to be able to reference some type of credible standardization. But in terms of developing the standardization, I think that the health field itself is moving in a direction where the military health system is recognizing that we need to be a part of that conversation to start developing some of that standardization. Coming from the federal space, I can tell you that government trying to facilitate alignment is really merely a suggestion. Sometimes government regulation is something that's almost as tricky as procurement language. And that is that my VA colleague is laughing because there's a very wide interpretation of regulatory language. And so I'm drifting off a little bit, but my point is the more we can, as healthcare systems, work with industry and the rest of this partnership, the more likely we are to be able to drive change. And so that standardization is not only something that we rely on, but we hope to be able to be a part to help create that.
So, Chip, I saw you leaning forward. Do you have some? No? Okay. Because certainly the policy of how you do that and how you do that at the federal level or allow the government agencies to kind of have that additional partnership is kind of an interesting take on it.
Yeah, and I think from the payer side, from the CMS side, that's really critical because you're looking to see what they're going to be requiring you to do. And I think there is this feedback loop from the measurement side and the measurement requirements that really needs to play into this also. I can't overstate that.
Any additional questions? Yes, sir.
Chip, yes, I do remember you from AHIC days, and thank you for your service back then and now. And I'm glad you brought up the policy issues around this because I did reflect earlier from the last one that I wondered how many lawyers by training were in the room. Just a few. How many practicing lawyers, like any trial lawyers? Because when I think about implementing a lot of these things, when I tried to start the research initiative at CRISP, the Health Information Exchange, it took me 6 months to work with the Hopkins lawyers and other lawyers to get to a data use agreement. That was just one part of it. And I do see that we have such an issue right now with how do we get past if you think about taking the Google concept of, let's just dump it all in someplace, get really smart about it, bring the app back that just has the small iteration for the machine learning's done and you're just testing the model against it and making an answer. That, I can see the lawyers of all sorts having a field day with all of that because our medical record has the risk of becoming fake news in a way. If we're able to more correctly and more perfectly represent it because we're taking away the inaccuracies of the, quote, factual data by algorithm, by inference, all sorts of things. We're making it more useful and we're making it somehow less true in a defensible sort of way. And I wonder how we're going to get through some of those issues as we address these bigger questions.
Actually, even to add insult to injury there, think about the deep pockets on the other side of those analytics when the trial bar looks at that and says, this mistake was made on this patient because of this analytic, and they got some pretty deep pockets. So they'll skip the doctor and just go right to the analytics. So I don't know if that works. But the trouble is, it is a lot of garbage in, garbage out. I don't know how to respond to that. I think earlier today there was the discussion about the underlying contracts, even for the agreements between vendors and providing institutions, and I think that you really got to think about your contracts for the analytics, because you know, there's going to be a lot of responsibility there, and it's got to be more than just what the service provides. It's also got to be who's obligated under what circumstances if there's a mistake. It could get complicated.
I mean, everybody, I think we all are aware that the best products come from iteratively working with those who have to use the system to develop it, right? And so whether that's an analytic algorithm where it's your own folks that are working on it and the rigor around starting with things that are not very prescriptively automation, but instead supporting the user in a way that simply supports them, gives them maybe an insight they didn't have before. But when you start looking at outside, where we are outsourcing an algorithm, or imagine that where we have this market of apps, you know, when I go to use an Apple app, I know that there's it's going to work largely. It's gone through some sort of testing that it'll work. Maybe not so much for other app stores, for example, right? But in healthcare, you know, if we end up with this, people want our data, and there's an app that somebody in their garage developed for diabetes, and then 3 or 4 people die because there was a flaw in it. You know, what is that counterbalancing process that makes sure that there's quality? And I think it's the same thing for analytics, you know. But
if I
to
could
get
just
the quality
riff on that
requires
a little bit.
iteration.
That same app could save 20,000 people and be really better than what we do today. But that's the bar that we have, and that's one of the reasons that we keep getting stuck, is because that defensive posture that we have in healthcare about it's better to be correct than to actually do something that works. Because you're right, we could probably make healthcare much better quality if we were a little less loose on the need. Okay, we kill a few people here and there in the process of riffing on ideas, but we ultimately get better, which is exactly what healthcare has done through the millennia. It's just we have a whole lot more people trying to be scared of that.
Peter, yeah.
Great comments, and many of you and highlighted this tension that when we think about the levers to drive this, and building on Julie's, Chip, as you said, there's got to be a regulatory framework. There has to be standards that are sufficient to guide it. There has to be a value proposition, and then those who buy it have to put some requirements, procurement. Curious, my sense is we have to think of these as evolutionary rather than revolutionary, that they're constantly going to evolve. As a non-IT person, my view is FHIR or other standards are quite well along to get us going. I think what you had presented, what the regulatory framework seems like it's there. From a provider side, I can guarantee you MACRA and MIPS, and I mean, we're all focused on value. We know we have no choice but to get it out. And so it seems that there is an opportunity to leverage, you know, Jim, as you were saying, to drive procurement to the same level that we do cyber. So if that's off, what other regulatory things or standards will we need before we start pulling these levers?
To me, I look forward to the initial and subsequent document in the trust framework that actually gives more and more granular clarity as we move from interoperable but not semantically interoperable to actually semantically interoperable. And it would simplify our cause if we could point to something and say that's what we mean. Are you certified? You know, that's very helpful to us.
I think that, let me answer it this way. I mean, I think that, I'm not so sure about 21st century cures. I think that HighTech, I think there are a lot of lessons to learn from it, and I think we wouldn't have the diffusion of the boxes without it. On the other hand, you know, I think that the way it required things was pretty ham-handed, even though many people in this room sat on all those committees that advised the government with the best of intentions. So I guess I would prefer to try a little lighter hand in terms of whatever ONC and CMS are going to do, and see whether some kind of model like the one that's described in this report with really, could work. Because that's why I talked about alignment and facilitation, not heavy-handedness. Because if you require people to do the kind of things that we saw in HighTech, they will do them. And they will buy products that do them because their first concern is compliance even before patient care, even though patient care ought to come first.
Comment on that. I mean, I think everything you say is correct, with the addition that in some sectors where there may be stronger incentives not to develop the expensive capabilities needed to meet this, let alone the opportunity cost of a company deciding to give up their platform stickiness, may require more than procurement, particularly when none of the players is planning to meet the requirement. So, just saying. It may not be enough of a lift in some areas. If you got a sector that has 10 companies, 3 of them adhere to the standard, great. We have leverage there. But if you have platform sectors that don't, then we may need a little wind in the sails beyond just a light hand.
But I'll go back to my accountability point. I think that if over time the machines and the ability to use the data with interoperability, and another issue, which I could bring up a lot of different issues, is attribution. I mean, who really did provide the service that you're ultimately being judged on in some pay-for-performance system? If all of that became sort of seamless so that these systems could provide that data in a way that really benefited the caregivers, that would be a tremendous incentive. If you know that all this stuff that right now, particularly for individual physicians' practices, is expensive and either meaningless, just checking off the box, or burdensome, either way, I think that would be a game changer. So I think if the government could figure out a way to use that less ham-handedly than it does value-based purchasing now for hospitals, I think it could.
Yeah, I want to echo what Chip says. To me, it's, there's an ocean to boil out there, but those who are entrusted with actually the sacred act of having delivered the health care, representatives of patients, those employers who are self-insured who are purchasing the value, and those who have to deliver, if that can be the driver for the use cases, then we have the weddedness of focusing the government on the right things that deliver value, in addition to tremendous procurement incentive. That's the marriage made in heaven.
So a couple of things, if I could, and I think hopefully you're seeing the irony of the person in the uniform, in the military uniform, advocating for more reliance on market force driving behavioral change. Has that been lost on anybody? So if I could speak to some of that, I'd recommend that people start paying attention to what we're trying to do in DoD, and look to see what this administration and the senior elected leaders are doing, as well as some of the things that you're seeing in the AT&L space, acquisition technology and logistics space, as well as what the Secretary of Defense himself is doing to move DoD into a more business-oriented mindset. I'll remind folks that within the military health system, we recently procured a commercial off-the-shelf electronic health record system. And we did that for a variety of reasons, notwithstanding the fact that we wanted to get something that would flex with the need to go forward and upgrade and do these things that we knew that we couldn't do organically. But the flip side of that is that in order for that electronic health record system to sit on our DoD information network, we had to ask that commercial vendor to change their security program in order to be able to provide that safe milieu for us to continue to work on the DoD information network, the DoDIN. But as you see that, you know, you're seeing that we're venturing out into the market. The other piece of this, and this is why I jumped at the opportunity when Peter and others asked me to participate in this conversation, is that we also have a keen recognition now, and we want to leverage this in a more productive way of the buying power that DoD brings to the healthcare space. So I think that, and I don't disagree with the need for regulatory guidance on this, but if you look at regulation, and I think your comment, I think, was spot on, is that people then tend to just check the box to meet the regulation, and then they do that to forego the other probably more important or loftier goals that are needed in your procurement. I think the greater power is being able to understand what this group collectively has the ability to drive from our respective levels and our respective leadership roles to see if we can't change and shape the market and our ability to do this in a way that doesn't rely on regulation.
Okay, with that, we were going to vacate the table, turn this over to the next panel. Mike?
Thank you very much, Karen and panel. Really extraordinary stage setting for our